Hey, Rob Fitzgerald again. Welcome back for another session in lab medicine. Very common ordered lab test. We're going to talk about sodium, potassium, and chloride. We have a separate section focused on bicarb when we talk a little bit more about acid-base. So we're just going to talk about electrolytes. Sodium is probably the most common lab test performed in the chemistry lab and probably in all of lab medicine. It's useful to know the reference range. It's fairly narrow, 135 to 145. You're going to see it a lot. You're not always going to have a reference range in front of you, so worth knowing about. So causes are of hypernatremia, so dehydration, diarrhea. Diarrhea can either cause both hypo or hypernatremia. It depends on the sodium content of the diarrhea. So if you're losing free water, you become hypernatremic. Hyperadrenalism. So again, if you remember the four things that aldosterone does, it reabsorbs sodium and it reabsorbs bicarb. It excretes potassium and hydrogen ions. You can figure out what's going to go on with your electrolytes in a variety of disease states. So Cushing Syndrome is a glucocorticoid excess that has some mineralocorticoid effects. So you get hypernatremia because you're reabsorbing the sodium. Same thing with aldosteronism. Too much aldosterone, you reabsorb sodium. You also bring water with it, so it might not be that striking, but you tend towards the hypernatremic. Hyponatremia, overhydration, diarrhea when you're losing a sodium-rich fluid. Intestinal fistula, so a fistula is simply an abnormal passage. Essentially, you're leaking out intestinal contents rich in sodium, so you become hyponatremic. You have low sodium in the blood. Addison's disease basically is destruction of the adrenal cortex, so you have hypoadrenalism. Renal disease, so you can't reabsorb appropriately, and so you get buildup of fluid, and typically patients become hyponatremic. Other conditions, salt-losing nephritis, so if your nephrons are losing salt, that makes sense. Uncontrolled diabetes, you're excreting keto acids and you're taking sodium with them as the counter cation, so you become hyponatremic. Dilutional hyponatremia is interesting in that when you're hyperglycemic, the osmotic activity of the glucose actually pulls water with it, and that's going to make your sodium appear to be lower. And so essentially for every 100 milligrams per deciliter of glucose above normal, you change the glucose, you bring in water, so you lower the glucose by 1.6 millimoles per liter. Prolonged use of diuretics, you're excreting sodium in urine, and SIADH is essentially inappropriate vasopressin, so you're reabsorbing too much water and you are hyponatremic. So hyponatremia with increased total body sodium happens essentially in fluid overload states. So renal insufficiency, heart failure, hepatic cirrhosis, all of the nephrotic syndrome, protein losing deficiency, all of these cause edema. And so you're retaining water and you become hyponatremic. Switching to potassium, again, very commonly measured, a very important cation. Fairly narrow range, 3.5 to 5.5. Critical values are 6, 6.5 range, so fairly narrow, narrowly regulated. Need to be aware that in cells, potassium is particularly high, and so if you have rupture of cells, you get an artificial elevation of potassium in either plasma or serum. So if you get in vitro hemolysis, so during the blood draw, if you lyse red cells, that's going to cause the serum or plasma to look red, and we're not going to be able to report a potassium there because we don't know what came from inside the red cells or what was normally in circulation. So hemolysis has a big effect on potassium concentrations. States of hyperkalemia, tissue damage. Again, tissue damage, you're leaking out intracellular contents of potassium, so you get an increase of circulating potassium. If you have renal problems, actually a fairly early sign of renal damage is hyperkalemia. So it's a fairly sensitive measure of, when I see a hyperkalemia, I think about, what's going on with the kidneys. Shock would be the same thing. Uncontrolled diabetes. Basically, diabetes, you are unable to utilize sugar, and the way that sugar gets into cells is it takes potassium with it, and so in that case, you get hyperkalemia. Dehydration, that makes sense. If you have insufficiency of adrenal hormones, you become hyperkalemic because aldosterone helps you excrete potassium. And if you don't have aldosterone, you become hyperkalemic. Hypokalemia, basically if you have a poor diet and you're not taking in enough potassium, that would make sense. Prolonged IV glucose or sodium chloride, essentially you're just diluting out the potassium. And sometimes what we see in the lab is, someone will draw a blood sample from above where they have an indwelling catheter, and typically what happens is that we get hypernatremia, but hypokalemia. So essentially it's a normal saline drip, so the sodium is going to be high, but our potassium and all the rest of our labs are going to be low. And so that's really an inappropriate sample collection. Vomiting, if you're throwing up potassium, you become hypokalemic. Same thing with GI fistulas, you're essentially just losing it. Diarrhea and adenomas, so if these adenomas produce mucus that you excrete, you become hypokalemic. Other causes of hypokalemia, aldosteronism. So aldosterone, remember, reabsorbs bicarb, and sodium excretes potassium and hydrogen. So if you have too much of it, you're excreting potassium and you become hypokalemic. Similar with hyperadrenalism, overdoses with ACTH, diuretic abuse and laxative abuse, again, just excreting those out either in urine or feces. Chloride, 98 to 107 as its reference range. I really think about chloride in relationship to bicarb because often chloride is sort of going the other direction of bicarb to maintain that electrolyte balance. Hyperchloremia, dehydration makes sense. If you're dehydrated, your sodium's high, your chloride's high, your potassium's high. Hyperchloremic acidosis, basically if you've lost bicarb, you, in like a metabolic acidosis, you still maintain that electrolyte balance by having more chloride. Stimulation of respiratory centers. And so if you breathe rapidly, you blow off CO2 and you get a respiratory alkalosis. You compensate a respiratory alkalosis renally, and so you start to excrete the bicarb. You excrete bicarb, you need something to maintain that electroneutrality, and essentially you get an increase of chloride because of the decrease in bicarb. High altitudes would be the same thing as stimulating respiratory centers. You just breathe harder because of lack of oxygen. Hypochloremia, overhydration. Hypoventilation would sort of be the opposite mechanism of hyperventilating. Same, and that's also related to pulmonary disease. Renal disease basically is inability to reclaim electrolytes from the glomerular filtrate, so you become hypochloremic. And in diabetic ketoacidosis, essentially you have a buildup of organic acids in the gamblegram, so our organic acids are going to expand, and both our bicarb and our chloride are going to go down because of the keto acids. So adrenal insufficiency, if you don't have any ability to maintain your aldosterone, you become hypochloremic. Hyperfunction of the adrenal cortex, metabolic alkalosis. So in that case, you have an increase of bicarb, and if your bicarb is high, then your chloride is going to be low. Vomiting, that's essentially throwing up hydrochloric acid, so you become hypochloremic. Fistulas, again, is leaking out chloride, potentially along with sodium. And really, I think about chloride generally goes in the opposite direction of bicarb, except for the setting of something like diabetic ketoacidosis, when your organic acids expand and both your bicarb and chloride would go down to maintain your electroneutrality. So that's a quick overview of very commonly ordered lab tests, sodium, potassium, and chloride, and I appreciate you tuning in.